Hi, my name is Jack Aiello. I was diagnosed with stage 3 multiple myeloma in early 1995. At the time, I had been married for 20 years and had kids who were young, 16, 14, and 10 years old. And I remember when the doctor told me that, well, at my stage, I was probably going to live for only 2 to 3 years. That was pretty scary. I didn't know what to say to my wife. I just remember we shared a good cry, and I remember talking to my kids and saying I had something wrong with my blood because I was going to be in the hospital for 96 hours. Meaning that instead of using my own stem cells, as was done in an autologous transplant, I used donor stem cells. It worked. And I haven't been on any treatment now since the early 2000s. Something I did right. I found that we had a myeloma support group in the Bay Area, San Francisco Bay Area, where I live. And they helped educate me about myeloma and questions I should be asking. So that made a huge difference for me. And today, whenever I talk with myeloma patients, I always suggest that they get a second opinion from those expert doctors. And there's so many more available these days from around the world. So to set the stage, I'm fortunate enough to be pretty knowledgeable about myeloma these days. And I've been asked to have a conversation about the recent ASH conference. ASH stands for American Society of Hematology, where the top doctors and researchers from around the world meet to discuss the latest in blood cancers, specifically myeloma. Two of those doctors are joining our conversation today. I'd like to introduce our two myeloma specialists. Dr. Josh Richter is Director of Multiple Myeloma at the Blavatnik Family-Chelsea Medical Center at Mount Sinai, and Dr. Muhamed Baljevic is Director of Plasma Cell Disorders Research at Vanderbilt-Ingram Medical Center. Both are committed to seeing myeloma patients in their clinics and also furthering research to get us those next improvements in treatments. Doctors, welcome. We will be highlighting the summary of top takeaways in myeloma from the ASH conference, because both of you were there, for first-line therapy patients all the way through later relapse. The big buzz at ASH for myeloma patients was the word bispecifics. But before we go there was some update that could actually change treatment for some myeloma patients today, and it has to do with steroids.
There was also an important piece of data presented in frail, newly diagnosed patients where we demonstrated that it's possible to cut back on dexamethasone completely. So this is really important for patients, and we've all received these questions, right? Glucocorticoids are not easy to tolerate with a multitude of side effects. So in these frail patient populations, where patients have multiple comorbidities, some may have diabetes, brittle diabetes, that's insulin dependent. It's really a success that we are presenting data like this, that we can show that it's safe and feasible. And quite frankly, even I in my own clinic and many others are sort of trying to see if we can pull back on the use of glucocorticoids long term. Perhaps in the beginning, there's some bigger role, but later on would be lower.
Thank you, Dr. Baljevic. Let's go now into the big area of buzz bispecific antibodies. Dr. Richter, can you help us understand what bispecifics are? We actually know about monoclonal antibodies like daratumumab, but what's a bispecific antibody?
So people may be familiar with monoclonal antibodies like Rituxan or Darzalex. It's got one arm, grabs onto the cancer cell and kills it. Bispecifics have two arms. And classically right now, each of those arms does this one thing. One arm grabs onto our T cells and activates them to attack the cancer. The other grabs onto the cancer cell. And whereas this arm that attaches to the T cell attaches to something called CD3, it's on all T cells. That, for the most part, right now is the same, but the arm that grabs onto the cancer cell is different. And here at ASH, we're seeing presentations from 4 different other arms. So CD3 and something called BCMA. And BCMA, some people may have heard of, it's the target of many of our CAR T therapies and a drug called Blenrep. Talquetamab targets something called GPRC5D. There's another drug called Cevostamab that targets FCRH5. And there's another drug that has a little poster about it that targets CD38, the same marker that's attacked for Darzalex, but also using the T cells. And that drug goes by the name ISB 1342. Doesn't have a fancy name just yet. Really excited about talquetamab because right now, the majority of our T cell redirecting therapies has all been BCMA. We have 2 FDA-approved CAR T cells. They both attack BCMA. We have 1 FDA-approved bispecific. It attacks BCMA. Up until November 22nd, we had an antibody drug conjugate called Blenrep. It was taken off the market, but there are 2 ongoing phase 3 studies, the DREAM-7 and DREAM-8 study, which will hopefully bring the drug back within the next year and a half, fingers crossed.
I personally think it's a good drug, and it's an important drug for, some subsets of patients. And actually, we have just learned that we will still be able to give that patient on compassionate access, actually. So I think that's important because not all patients will be eligible for CAR Ts, maybe even for bispecifics.
Speaking of that, let's talk real-world access for patients and caregivers. How soon are we talking with all of the bispecifics?
So that's a really great question. So teclistamab was approved. We have started giving the drug commercially. It's available. So as opposed to a CAR T where there's limited slots because of production, this drug is available. But let me put a little caveat on that. So right now, the way the drug is recommended to be given by the FDA is that you get several step-up dosings, and this is done mostly inpatient. So you have to be admitted to the hospital for about 7 to 10 days. We can't admit 30 patients at a time. So every institution is developing their own SOP of how many patients they feel comfortable with a week. So right now we have a list of patients that have been waiting, and now that we're giving the drug, we're going through that list pretty quick. So my guess is that within the next couple of months, we will have gotten through that list and we'll be able to say, okay, you're progressing, you need the drug, you can get it. It's going to happen a lot faster than for CAR Ts.
And how about true availability? For instance, CAR T has been limited to certain sites, mostly bigger and academic hospitals. Will bispecifics be available for those of us getting care in the community?
So that's a really, really great point. The short answer is yes, it is, but it's not going to be given in the community just yet. So a lot of this is there's still pretty high rates of CRS. It involves the admission. It involves some of the management strategies that a lot of these doctors are not as familiar with. A lot of hematologists, oncologists out there are used to dealing with side effects of classical chemo. And then they got used to dealing with the side effects of checkpoint inhibitors. And now there's going to be a learning curve. So one of the things that we're willing to do is partner with the community. You come to us, you get that first inpatient dosing, we get you through the risky part, and then get you back to your community to get your regular treatment.
We hear a lot about CRS, cytokine release syndrome, as a side effect, especially when it comes to these T cell therapies. Dr. Richter, can you share what it actually looks like in patients from low grade to high grade when they experience CRS and how it's managed?
There's a grading system, and I would lie to say that I could rattle off every facet off the top of it. But for the most part, Let's just first even break down what is grade 1, 2, 3, what does it even mean? There is something called the CTCAE, the Common Terminology of Adverse Events, and it grades everything from a grade 0 to a grade 5, from stubbing your toe to a heart attack to CRS. Grade 0 is you don't have it, 5 is you've died from it, and 1 through 4 is gradual worsening. And in clinical trials, we often look at grade 1, 2 as being the milder ones, and 3, 4 the more serious ones. In general, grade 1 CRS is just some fever. You spike a little temperature, you feel fine, your other vital signs are fine, you're not having any trouble breathing, anything like that. For grade 1, you don't really need to do anything. If it persists, you can start adding drugs like tocilizumab. For early grade 1, you can just give Tylenol if you want. So even simple things like that, a little IV fluid, a little Tylenol, settle them down. Grade 2 is where you're starting to have, your pulse is getting a little faster, or your blood pressure is starting to drop, or your oxygenation, your oxygen levels. I think we all got used to COVID with those O2 sats. If your O2 sat starts dropping, that's starting to get into grade 2. That's where we're really coming out there with things like tocilizumab. And then as we get to 3 and 4, that's where oxygen is getting worse. You may even need more oxygen support, even getting to the point of being on a ventilator, not very common.
With that in mind, will bispecifics be able to be given in the outpatient setting?
There are already a number of people starting to give these completely as outpatient. There are certain risk factors for higher grade CRS. So if you have a very high tumor burden, we know you're more likely. If some certain markers like your LDH are already cranked up, we know you're more likely to have it, or circulating plasma cells. So if we have someone that doesn't have all those risk factors, we could give it as an outpatient. But there's actually some data from another bispecific being presented here at ASH that I think is going to make it more applicable to the outpatient.
For teclistamab, there's the initial 2-step dose, then the third full-strength dose, all given at least 48 hours apart, so that then patients are required to be in the hospital to manage possible side effects for at least a week. What are your thoughts about the requirement for patients to be hospitalized with bispecifics for the time being and the burden associated with that?
So this is really important because it's really essential that we use this drug safely. The label is advising that the inpatient admission and monitoring be considered for each of the doses in this step-up schedule, which is basically 1, 4, and 7. 7 being the first, full dose that they would continue with. So potentially, yes, that does imply that perhaps people would need to spend 9 days in the hospital. There are a number of efforts that are going to be attempted to try to see what can we do. Can we even consider perhaps doing some of this therapy in the outpatient setting partially or maybe even fully? There's also possibility of having sort of slightly different step-up schedule of 1, 3, 5 with maybe 7-day admission rather than 9. So cutting back a little bit on the days spent, which has an impact on how hospital systems can deal with the costs associated with therapies and reimbursements for these therapies. So really important period ahead for how this drug is going to be used in the broader sense in academia, but also in community, importantly.
So cevostamab is another one of those bispecifics. CD3 to grab onto the T cells, something called FcRH5 that's on all the myeloma cells. And there's 2 presentations that are here at ASH that I think in and of themselves wrap into a nutshell how we are likely to approach all bispecifics in the future. If you put them together, this is the blueprint. So number 1, we're talking about CRS. We recognize that for some people, they're going to end up in the hospital or have higher grade or get sicker. And when you develop CRS, we give them a drug like tocilizumab. Well, what happens if you use it as a pre-medication? What happens if you give it before you even give the first dose? Can you mitigate or prevent CRS? And that's exactly what they did for cevostamab, where they took patients and they gave them a prophylactic dose of the tocilizumab, we call it TOCI, and it took the overall all-grade CRS rates from over 90% down to the 30s percentile. And that's just the beginning. People will say, well, wait a minute, if we give TOCI, are we going to affect the efficacy? For cevostamab, absolutely not. So we have not affected efficacy, but we've markedly reduced the incidence of CRS. So we're all starting to talk about how we're going to approach this. Should we consider giving people tocilizumab before we give them bispecifics, particularly for the people we worry may not tolerate it? So 40-year-old, no medical problems, not as worried. 80-year-old, multiple comorbidities may not be able to tolerate that grade 2 to 3 so bad, considering giving them tocilizumab.
So I think that's really interesting, because we may yet use the findings of that cevostamab study to try to perhaps plan how we can reduce the incidence of CRS and other bispecifics, and maybe even in the CAR Ts. So you're right. Bispecifics, a lot of interesting data presented.
There is also research pushing towards the possibility of limited duration treatment with bispecifics for relapsed refractory patients, meaning not having to continuously be on treatment. Can you share more about this?
The whole standpoint is treat until progression or intolerability. We don't stop therapy. It's true for all the bispecifics, except cevostamab. This is fixed duration, 17 cycles, which rounds out the drugs every 3 weeks. So with step-up dosing, it's 1 year of therapy, and then you stop. And now we're starting to see patients who've completed that, and we're monitoring them off therapy. And in that trial, they have the option of being retreated if they progress while they're off. And we have patients greater than 6 months, and we have a number of patients greater than 12 months. So now patients who've completed a year of therapy and are now another year in complete remission off of everything, living their lives. And if at some point the disease comes back, we come right back in with a drug that put them back into remission. Now, this gives us a number of advantages. Number one is obviously how patients feel. But there's 2 other big ones. One is something called T-cell exhaustion. So if you give these drugs that activate the T cells and you say, fight, 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 eventually they get tired. And maybe they're getting tired at a point where you don't need them. And when you do need them, they're not ready to go. So giving someone a break off the drug, those T cells can recuperate. And when you need them, they're back ready to fight.
And deeper understanding of T cell function, T cell exhaustion, and resistant mechanisms is needed. And that's where some of these other agents that have positive impact in those situations can maybe lend themselves even more useful. So, for example, Selinexor is such an agent where some of the preclinical data has already been published and demonstrated maybe some of these roles.
Is the hope that other bispecifics can also test this finite duration?
Absolutely. That is the big buzz when you talk with all of the pharma companies here, because why did cevostamab, why did they choose a year? We even asked them in the meeting yesterday, and they couldn't give an answer, but I'll give the answer. 1 year is a nice round number. It's not a biological thing, it's a nice round number. But what this is becoming thought-provoking for all the other bispecific manufacturers is to say, we need to do this, but with a biological endpoint. For example, complete remission and then 2 more cycles and then stop, or MRD negative and 3 more cycles. But right now, this is the big discussion, is not to just pick a random number, but to have a biological response. And right now, these are the big discussions in the halls of ASH, is how do we design the next series of trials?
Remind us, who would qualify for bispecifics?
You can say patients who've had 4 or more prior lines. Or another thing we talk about is triple class refractory. So refractory to a drug like Revlimid, a drug like Velcade, and a drug like daratumumab. And now we're even going the next step, also refractory to a drug like a BCMA drug. But what we know is once that gets those approvals towards the end, we start learning more, we move it further up, new combinations. So there's already trials in bispecifics in 1 to 3 prior lines, and a few that are on the verge of opening as upfront therapy. Very new, not a lot of people on them. So we're still trying to figure that all out. But Dara had a response rate of 30% in the end. And when you give it upfront in combination, it's 100%. What happens when you take a drug that's 70, 80% response rate in someone who's had an average of 6 prior lines? If you move it up front, do you cure some people? Do you get remissions that are so long it's a functional cure? So that's why the myeloma world couldn't be more excited right now. You know, there is a combination out there. And there are actually several discussions right now among some of the big groups that we've been part of as well, of cure protocols and cure goals.
Dr. Richter, what's the overall takeaway so far on the CAR T cell therapy front?
The CAR T front is that, so they work well in the later lines. And what we were initially worried about is if you move those further up, we were worried about more side effects, because it's all about the T cells again. As you go through your therapy, those T cells get tired. And when you give a CAR T or collect T cells in someone who's had a whole bunch of therapy, you're collecting tired T cells. What we were worried about is if we collect early on T cells that are more robust, maybe they're going to give you more side effects, more CRS, more neurotoxicity. That has not happened. That's not the case. So we know that we can give these drugs early on. But some of the early data has been extremely encouraging. And the big question is it better than other therapies early on? Now, there's a study called the KarMMa-3 study, which compared ide-cel versus an early regimen in relapse like Dara-Pom-Dex. We don't have the data just yet, but there was a press release to say that CAR T beat it. So a lot of excitement about moving CAR Ts into early relapse. And then there's two strategies right now about CAR Ts and upfront. One strategy is comparing CAR T versus transplant. And that's a really interesting one. But that's not my favorite. My favorite is transplant and followed by a CAR T, with the idea of your induction brings you down to here, your transplant brings you down to there, and then bringing in immune therapy to sweep up what's left. And I'm hopeful that that might be a curative approach for some people.
You were talking about how sequencing is going to matter, but also in choosing which direction to go. For your patients, how are you going to decide or determine whether it's going to be CAR T first and then you go to bispecifics, or the other way around?
Yeah, that's really important. And we're still learning, how to recognize what the best patients are. Personally, if I have a patient that can receive CAR T therapy and I'm in a position to give them CAR T therapy, I probably will do that preferentially. Though we now have a first agent that's bispecific, and that's off the shelf by definition. And we are perhaps expecting another number of agents in 2023, maybe Q2. We may see a couple of agents come through, maybe one for targeting BCMA, another one for targeting GPRC5D for the first time. I think that both are associated with some of the serious side effects. CAR T, of course, particularly speaking, autologous CAR Ts, right, that we have on the market, they are associated with some requirement for generation and synthesis. So patients that are relapsing and that have diseases with velocities that are pretty, aggressive, and whose proteins are rising rapidly, whose counts may be changing, or whose kidney functions and mineral levels and calcium levels might be threatened, they may not perhaps be the best candidates for those types of therapies. They're better candidates for off-the-shelf therapy. So that doesn't only include BiTEs, but it may also include allo-based, CAR T cells off the shelf.
It's all in context, right? So if you look at some of drugs like Dara that was 30% response rate, like 6 months or so, and heavily refractory, we use it up front. Let's say the Maya regimen, Dara-Rev-Dex for elderly transplant-ineligible patients. The average remission up front is greater than 5 years. So what does that look like with CAR T? We're still trying to figure that out. So let's say the two are equivalent. Giving someone standard therapy or CAR T, there's risks and benefits. CAR T, you have to be admitted. Standard therapy, you don't. CAR T is a one and done. Standard therapy, you have to continue on. CAR T is usually something that we reserve for the younger and fitter. If you're older, frailer, the other direction may be the way to go. But the other question is, until CAR T is a one and done cure, we're trying to improve those remissions. So there's a number of studies looking into maintenance after CAR T.
Were there any updates on CELMoDs?
These drugs, just like Revlimid worked in people who had thalidomide and pomalidomide worked in people who had Revlimid, these drugs work really, really well in people who've had the others. And iberdomide, for example, is one of the most potent ones, and it has a lot less in terms of what we call myelotoxicity. It doesn't lower your blood counts as much. So if you wanted to strategize an optimal maintenance drug, a pill, it'd be a drug that someone's going to tolerate very well and not lower their blood counts, especially after something like a CAR T, where your counts may be lower. So these CELMoDs are really going to be a big part of our therapy. We probably have to wait till 2025, 2026 for the regimens like Velcade Iberdex and Dara Iberdex. But there's some already push to kind of consider those drugs in earlier lines. So really, there's a number of great drugs on the horizon.
What role do the more recent novel therapies play now?
So right now, if you look at the CAR Ts and the bispecifics, it's patients who had at least 4 lines of prior therapy. Well, if we're giving Dara RVD up front, and you're getting CAR Pom Dex in your second line, you got a gap in there. Now, that gap is very important because if you're going to collect T cells, if you're going to collect CAR T, you can't give a drug that kills T cells. So, for example, bendamustine is a drug that a lot of people had been using in that line. But bendamustine is a great lymphoma drug. It kills lymphocytes. So if you give benda and then you try to collect CAR Ts, you will fail. Selinexor is an excellent drug in there. So we've been using a lot of it there to help bridge the people to get them to CAR T.
Dr. Baljevic, speaking of Selinexor, you presented additional details on using this drug weekly instead of twice a week, providing efficacy with fewer side effects. Both the STOMP and Boston trials used this lower Selinexor dosage in combination with carfilzomib and Velcade, respectively. Can you expand on this topic?
We are shown the value of Selinexor as an agent in this difficult to treat population. Earlier, we were talking about the outcomes of high-risk patients. Anybody who is triple-class refractory, even if they're not harboring high-risk cytogenetic features, they are biologically, already in a place where they have progressed on, multiple good therapies. And we know from previous large-scale analyses that these patients have a short, median progression-free survivals and survivals that are measured in single-digit, outcome endpoints. So what we did there is we looked at the patients that were exposed, and some of which were actually refractory to CD38-based therapy as well. And we looked at what type of outcomes they can have with Selinexor-based, importantly, weekly treatments, right? So a lot of investigators still have angst using Selinexor twice a week. I agree with that. I've never given anybody Selinexor 80 milligrams twice a week. These are active triplets with Kyprolis index, with Pomalyst index, even with Velcade index. So Boston data phase 3 was, positive report. But particularly with the, second generation PIs and IMiDs, POM and Kyprolis, these are powerful triplets that are effective in this difficult to treat population. In fact, it's going to be really important for us to try to understand what is the best way for us to try to utilize agents with different mechanism of action. How are we going to treat patients who are triple class refractory and BCMA refractory potentially, because a lot of these agents are being brought in early. So KarMMa-4, CARTITUDE-5 are exploring the use of CAR-Ts as a part of the first line. CARTITUDE-4, is going to be looking at cilta-cel versus two different standard of care, options, PVD versus DPD. So, that, some patients there will potentially be treated in the second line, right, with powerful agents. So what do you do with those patients? Well, we don't know. We're just generating that experience. So we need agents with different mechanism of action. We need agents that we can rely on that can actually treat this difficult to treat patient population.
Wonderful. We are seeing more and more on diversity, equity, and inclusion, or DEI, addressing the needs to make sure that we are more inclusive of different populations. What can pharma, doctors, and patients do to increase diverse populations in clinical trials?
This is such an important question. We are not doing such a good job in myeloma field as myeloma specialists accruing minorities and disparities. We have data on that. For example, African American population is still being accrued in the single digits on clinical trials, so that's a problem. And some of the other, disparity populations as well. So, for example, where I practice and where I, am in charge of the program, that's really a programmatic goal for us to try to do better and increase disparity accruals on clinical trials. In fact, we have a grant with LLS. So LLS is really an amazing partner in so many areas, and they're supporting increase of the awareness and access of patients from the community areas, especially those that are underserved geographically. So we're partnering successfully with colleagues in the community in trying to bring patients and increase the access to good quality clinical trials for hematologic malignancies in general, including in myeloma. So we need to do a better job. And thank you for asking that question. That really needs to be a goal of every single myeloma physician. So hopefully we're going to see in the future more trials that have sort of more balanced accruals in terms of different ethnicities, different disparity populations in particular.
When I started this and people were diagnosed, I said, "We can't cure this disease. I'm very sorry." Today, we cure some people, a small number, and I will admit it's by accident. We don't know that we did something extra special good for that particular person. The next generation is intentionally curing more with the goal of intentionally curing everyone. And we have the pieces to start getting closer and closer to that.
Thank you to Doctors Richter and Baljevic for joining this discussion about the latest in myeloma treatment as we head into the new year. There was an incredible amount of myeloma information at the recent ASH meeting, and you've helped distill it down for patients to be able to understand. And patients, thank you for joining us, because all of this information comes your way and is important for your own education and enabling you to be your own best patient advocate. Doctors, I'm so glad you joined us for this discussion at The Patient Story.